Good evening, everybody, and thank you for your attention. My name is Melissa Treby, and I'm the Cancer Education and Screening Manager in the Cancer Prevention and Research Division at Cancer Council WA. And tonight, on behalf of our team at WACOG and also the GP Education Project, I'd like to welcome you to our event on genetics and cancer, and thank you so much for coming. Before I go any further though, I would like to do an acknowledgement of country, and I'd like to acknowledge the traditional custodians of the land on which we meet tonight, the Noongar Whadjuk people. I'd also like to pay respect to the elders past, present and emerging, and offer our acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present here today. And by present, I also mean to the virtual world. We do have people joining us today on Zoom, I believe. So they may be meeting on different lands to the ones that we're meeting on, and therefore I'd like to acknowledge that too, that wherever you are watching this from tonight, that you are also standing on the lands of traditional custodians. Before we progress, I would like to acknowledge the sponsors. So this event tonight is sponsored by WACOG, which is the WA Clinical Oncology Group, which is an education program at Cancer Council WA, mainly designed for the tertiary setting, the oncology coalface, if you will, clinicians, oncology nurses, clinical trial specialists, people like that. They're sponsoring us tonight. And also, of course, the Department of Health of Western Australia, which sponsors both the WACOG program and the GP Education program at Cancer Council, without whom we could not be here tonight. So thank you very much to the Department of Health. A couple of little housekeeping things before we start. I'm sure you've already realised where the facilities are. Just as you came in through the main door, you'll find both the men's and ladies' facilities. Please take this opportunity to turn your phones off or to silent, and just check, because there's always somebody. Thank you very much. Finally, just to let you know that we do like to evaluate all of our events, education events at Cancer Council, to try and first of all ensure that we're doing a good job of providing education, but also to get some ideas from the people that we're trying to get education messages across to. We'd like to know what you want to know and what we can do to further help with your professional development when it comes to the entire spectrum of cancer, from prevention right through to survivorship or palliative care. One last thing, today we have several speakers. We actually have 3 main speakers, but then at the end we're going to hold a question session. You'll see there's 5 chairs perched on the end of the stage. So what I will do, if you don't mind, is ask you to hold your questions for each of the presenters, because at the end we're going to gather all the experts onto the stage together, and then I'll invite questions. At that point, Claire, who is one of our WACOG team, Claire will put her hand up over there. She's going to run around with a roving mic. I would ask you to please wait for the mic, because people on Zoom won't hear your questions if you don't. And of course, that's not a good experience for them. So if you could please be mindful of that, that would be fabulous. Thank you. Last but not least, I did mention the evaluation. You should be receiving at some point during the evening, probably just after the event finishes, an electronic evaluation to the email address by which you registered for this event. We really would value your opinion. So if you could take the time either tonight or in the next couple of days to complete the evaluation, that would be greatly, greatly appreciated by the whole team. Okay, so I have definitely spoken enough now. And at this point, I would like to introduce our first speaker, Sarah Long. Thank you, Sarah. Sarah is a genetic counsellor. Sarah is a Human Genetics Society of Australasia certified genetic counsellor working in the familial cancer field. She is currently also an associate lecturer at the University of Technology in Sydney. Her interests are bioethics, patient autonomy, and the new and emerging technologies. Please join me in welcoming Sarah. Thank you.
It's a very special day for genetic counsellors today. It's Genetic Counselling Awareness Day. So, so it's a bit like our birthday, except we don't get any presents. So what I thought we'd do is have a bit of a chat about our service and what we can offer, and then run through some of the familial breast cancer syndromes that we see, and present a bit of a pedigree so you can see some of the familial cancer syndromes and what they look like. So genetic counselling, this is the very formal way of describing it, but at a party, when someone asks me what on earth I do, I say that my job is to give people information in a way they can understand so they can make their own choices about their health. And that's what we do. It's a communication facilitation process. It involves communicating both psychosocial issues as well as medical and scientific information. We're a statewide genetic service, and we're the only public genetic service in WA. We've got several different departments. So we're from familial cancer tonight. We also have our paediatric department, our cardiac genetic counsellors, our adult and prenatal area, and we have a renal genetic counsellor as well. So we're quite a big group. And we're made up of genetic counsellors, clinical geneticists, our research team, and our familial cancer registry as well. We do several metropolitan clinics. So we're at King Edward mainly, but we also go to Joondalup and Rockingham, and we have outreach clinics that we go to. So Geraldton, Port Hedland, Bunbury, Kalgoorlie, Albany, and I think we go to Broome every now and again as well. You can imagine we all fight to get to go to Broome. So when do you refer to us? Now, this is the absolute genetic counselling familial cancer Bible, is EVQ. It's evidence-based guidelines, and there's a whole page for general practitioners, oncologists, nurses, when to refer a patient when you've got a family history. So I strongly encourage people to look at this website. I couldn't go through all the referral guidelines in one night. So what is our role? What do genetic counsellors do? So we assess the likelihood of having a genetic mutation, and we do that through different algorithms and programs, some online and some much simpler. We assess the risks to the client and the family members. We see patients at appointments to discuss genetic testing, implication and outcomes. We arrange the testing, we give the results, and we counsel with the psychosocial issues that might come from those results. A lot of us attend multidisciplinary meetings to consult with other professionals, and we make screening recommendations for patients as well. What we don't do, so we don't tell people they have to have a test. We facilitate decision making. We don't tell people to have prophylactic surgery. Again, we facilitate their own decision making. We don't manage long-term patients. So we might see them, do the diagnostic or predictive appointment, do the follow-up, but we don't manage people in the long-term in familial cancer. And we don't do the laboratory work, which is wonderful because it's very, very difficult work. And we don't arrange the screening. So we ask the patient's GP to arrange long-term screening like colonoscopies or breast surveillance. What do we test for? So when I first started, it was breast cancer, bowel cancer, and every now and again we'd get something really exotic. Now it seems every day we're getting a huge range of different cancers and different syndromes we test for. And these are just some of the syndromes we test for, and each of those might have several different genes involved. So you can imagine our panels of genes now are just huge. And only a small proportion of cancer is genetic. So we're really just seeing that 5 to 10% where there is a strong familial cancer history. So I thought we'd focus on the breast cancer predisposing syndromes because a lot of people have heard about BRCA1 and BRCA2 and Angelina Jolie, but there are so many more than BRCA1 and BRCA2, and they're quite interesting. So I thought I can't cover everything tonight, but I'll go through some of these ones. So like I mentioned before, most people here probably know only about 5 to 10% are due to inherited factors. There's a larger group that we call familial, so there might be lots of different genes interacting with environmental factors, but it's not a single gene disorder. And then the majority is sporadic. So the process is once somebody gets referred to genetic services, we usually send out family history forms, or we might give the patient a call and collect family history over the phone. Once we've got the family histories, we validate all the cancers possible, and I'll explain what that means in a minute. And assess if testing can be offered. So with breast cancer, we use the Manchester criteria for BRCA1 and BRCA2, which is basically how old people in the family are when they got cancer, and it's adjusted for histology. There's also an algorithm online called Bodicea, which is amazing. You pump in the family history details. You need quite a lot of information. It'll give you a risk of having a genetic mutation. At our service, people immediately qualify for testing if there's breast cancer under 40 years of age. It used to be a lot lower, but we've sort of adjusted our threshold. Grade 3 triple negative IDC under 60, we will automatically test for because there's a link to BRCA1 and triple negative breast cancers. High-grade serous ovarian cancer has actually been mainstream, so it doesn't have to come through us, and oncologists can order that testing. And breast cancer in a Jewish background automatically qualifies for testing for the 5 mutations found in the Sephardic and Ashkenazi Jewish communities. So I mentioned validation, and this is actually a very time-consuming but important part of the process. And what we do is we access medical records and death certificates from families to make sure the cancer is what they've told us it is. And this is really important for the gynecological cancers because it so often happens that people get confused with a uterine or a cervical and say it's an ovarian, and that really impacts the risk we're going to give someone. To the point where if there's a strong family history of ovarian cancer but no one we can test, we might actually say you could consider having your ovaries removed. If that's cervical cancer, we don't want to be giving people recommendations on that. So here's a death certificate from 1988 that a relative managed to get, and we could confirm it was uterine cancer, not ovarian cancer. So that made a huge difference in assessing their risk. So at the moment, here are some of the genes tested on our standard panel. You can see there's BRCA1 and BRCA2 and a couple more exotic ones that I'm going to run through. And there's also some additional genes that are not on our standard panel, but if there's clinical indications, then we'll test for them. So here are some of the breast cancer predisposing syndromes. You've got BRCA1 and BRCA2, CDH1, I'm going to go through these separately, P10 hamartoma tumor syndrome, Leigh-Fraumeni, the ATM variant, neurofibromatosis type 1, Peutz-Jeghers syndrome. And if you come from our department, you'll know that there's a bit of a giggle there because we once had a doctor refer for Ponce-Jaguar syndrome. So Peutz-Jeghers always gives me a giggle. CHEK2 variants, and there's probably quite a lot of unknowns as well. So BRCA1 and BRCA2 are the most well known, and they're probably the most common. About 1 in 500 people will have a BRCA mutation. And when you think about how common breast cancer is, with 1 of 8 of us getting it, and you think about the 5 to 10% that's genetic, it does actually make sense that it's not that rare in genetic terms. A lot of this is sort of self-explanatory. So a lot of the red flags are ovarian cancer, male breast cancer, high-grade prostate cancer, especially at young ages and across multiple generations. Interestingly, the histology of the ovarian cancer is really important. So high-grade serous is linked to BRCA mutations, whereas mucinous and borderline are not. So we actually don't count those when we're getting referred a patient. BRCA genetic testing, as well as a lot of other genetic testing, works in a bit of a flow chart. So once we've decided that a family meets a criteria, and it has to be a 10% criteria for finding a mutation, so it's not a huge criteria, then we decide to offer testing to someone with cancer in the family to give us the best chance of finding a pathogenic gene mutation. That's a diagnostic test. We don't know what we're looking for, and we go through the BRCA genes to try and find a mutation. If it's inconclusive, we don't call it negative in our department. We say it's inconclusive because we don't know that there might be other things out there that our technology can't detect, and there might be other genes. So we give an inconclusive result, and that's about 80 to 90% of the time, which is quite frustrating. If it's a positive result, it means we've identified a gene mutation. We can offer testing to other people in the family for that specific gene mutation. And then testing becomes quite simple. It's a predictive test. It's either positive or negative. You've got the gene change or you don't. So this is a real pedigree. I hate the word pedigree. It makes people sound like they're in a dog show or something, but that's the technical term for it in genetic counselling. So this is a real pedigree, and you can see that there's some red flags up there. So there's a male breast cancer. It's at an older age, but male breast cancer is a big red flag. And that man also had prostate cancer, so he was pretty unlucky. Then there's a high-grade serous ovarian cancer in the next generation, and there's also 2 breast cancers, and they're not at particularly young ages, but when you see the high-grade serous ovarian, the 2 breasts and the male breast cancer, red flag should immediately be going off. Interestingly, in the generation where there's a male breast cancer, there's no other cancer. And that can almost be a bit of a red herring. But if you look at the family, those squares all represent males. While males can have a BRCA mutation, they're much less likely to develop cancer. So if there is a mutation there, it can be masked by those males, which is why it's so important for us when we're taking a family history to find out how many affected people there are, as well as unaffected, and what gender they are as well. Hereditary diffuse gastric cancer caused by the CDH1 gene is a bit of a rare one. You get diffuse gastric cancer plus lobular breast cancer. The prevalence is not known, it is quite rare, but there's a large cohort in New Zealand, and it's a very difficult cancer to do surveillance for. So because the diffuse gastric cancer isn't easily picked up on endoscopy, people with this gene change do have a prophylactic gastrectomy. So this is a diffuse gastric cancer family, and you can see that there's a very young age of onset of gastric cancer at 32. And there's a breast cancer just in the next generation as well, and another gastric cancer. Interestingly, with this family, the intervening relative was negative, and there's 2 people with breast cancer in the next generation. And what this means is maybe there's other factors. So when we do a family history, we have to take the maternal and the paternal family history. You can't just assume that all the cancer must be caused by the mutation in the family. So P10 hematoma tumour syndrome includes Cowden syndrome. And Cowden syndrome is one that's relatively rare, so 1 in 200,000. And you get multiple non-cancerous growths, but there is an increased risk of things like breast cancer as well. So you can see that female breast cancer is possibly around 30%. Some papers quote as high as 80%, but it's really biased on how they selected the participants in that study. When we see follicular thyroid cancer, that's another clue, and endometrial cancer. Interestingly, people with Cowden syndromes tend to have macrocephaly, so slightly larger heads than normal. So one of the things I'll work up over the phone is asking someone if they have trouble finding a hat. And this is a really good way of saying, do you have an abnormally large head? But slightly nicer. And they can also have skin lesions. So if we have a patient we suspect has Cowden syndrome, we'll usually get a clinical geneticist to see them so they can do a skin exam and have a look at those features for us. And here's a Cowden syndrome pedigree. So you can see the thyroid and breast cancer, which isn't that uncommon to find in a person. Like lots of people have had both of them, but it's in presentation where you've got people with the folliculomas and multiple polyps as well. And then we did a gene test and we found a P10 gene mutation in this family. Lee-Fraumeni syndrome is one that's had a bit of media attention lately. There's a little girl who's been in the papers who very sadly has a brain tumour, and she has this condition. I'm not breaking confidentiality, it's been all over the news. And she's been travelling back and forth to New South Wales where Dr. Charlie Teo is, or Victoria. And unfortunately, this condition is pretty serious. So the prevalence is sort of variable. It could be as high as 1 in 5,000 people. And the penetrance is extremely high. It's a 95% chance of cancer if you're female before the age of 60. It's a tumour suppressor gene, which means that normally it works to control how cells grow. So when it's not working, cells grow out of control, and we all know that's what cancer is. It has a de novo rate. This means that it's quite possible to see someone for the first time in the family that has a mutation and their parents don't have a mutation. So it started for the first time and that happens about 7 to 20% of the time, as the rest of the family will thankfully be unaffected. The reason this one is so important is because if you have a gene change in the TP53 gene, you have to minimise exposure to radiation, because radiation, CTs, any of that will cause more cancers to grow. So we quite often get asked for very young women with breast cancer to do treatment-focused genetic testing, which means get this result through before the potential for radiation therapy happens. So this is a bit busy, but just to give you an idea, if you're a female with Lee-Fraumeni syndrome, your risk of breast cancer is 85%. Your risk of a tissue sarcoma is 50%, and your risk of brain cancer is 20 to 30%. Unfortunately, unlike a lot of other ones, this does affect children. So we do test people at quite a young age, and it's not unusual for very little children to be affected. So look at all the colours. This is a Lee-Fraumeni syndrome pedigree. You can tell from all the different colours. Unfortunately, it's a very sad pedigree as well. You can see that one of the red flags shows a very young onset of brain cancer. So both children were under 10 and passed away. And their parent was 40 with pancreatic cancer. And then you've got the next generation of brain cancer at 45 and very young breast cancer at 29 as well. So this is pretty awful pedigree, but somewhat consistent with Leigh-Fraumeni syndrome. And our client had prostate cancer and he was negative. So that was just your normal background risk of prostate cancer that anyone else can have. But thankfully he was negative and he can't pass that gene change on to his children. PALB2 is one of the newer breast cancer genes that we've been testing for, and we're learning more about it all the time. So if you've got biallelic mutations, which means both your copies of PALB2 have a mutation, it can cause Fanconi anemia, which is quite a serious disorder and life-limiting. But if you get a certain type of mutation called a truncating mutation, which cuts the gene short, and you have it in one copy of your PALB2 gene, then you've got an increased risk of breast cancer, which just goes to show how amazing genetics is, that you can get all these different things happening from the same gene. A little bit biased here. So the risk of breast cancer with a PALB2 gene mutation is about 50%. And we used to say, oh, there was no risk of ovarian that we could prove, but the evidence has come out and shown there's about a 5% risk of ovarian cancer. So not huge, but still enough to say, well, that's, 1 in 20 people with a PALB2 mutation will get ovarian cancer. And the recommendations are to remove the ovaries about the age of 50 at the moment. This is a PALB2 pedigree, and it was an interesting one because a lady who had the breast cancer on the lower generation was found to have a PALB2 mutation. Her mother had bilateral breast cancer. Her mother was negative, so it's from the paternal side of the family. And again, this happens because breast cancer is so common. You just can't make assumptions, oh, there's breast cancer there, it has to come from her side. It's why testing people in the family is so important to see who's at actual risk of the mutation without making assumptions. ATM is another one that we've just started testing for, and we actually only look at one specific mutation. So one specific mutation is the 7271 T to G, and it's only that mutation that is linked to an increased risk in breast cancer, which is about 47%, and pancreatic cancer may be increased as well. Interestingly, again, if you have 2 mutations in the ATM gene, you'll get ataxia telangiectasia, which is a cerebral neurodegenerative sort of condition, which I've summarised there. And it's quite serious, but people who carry AT don't necessarily have a high risk of breast cancer unless it's that specific variant. So it gets quite complex. This is a pedigree that is one that's a bit of a headache because we found an ATM variant. Unfortunately, there's breast cancer on both sides of the family and both the parents of that person are deceased. So without further testing, we don't know who's at risk. And there would still be residual risk to the family that doesn't have the ATM variant because of their family history, if that makes sense. I haven't got too long to go. Am I going all right for time? Yeah. So NF1 is one that you see a lot in pediatrics, neurofibromatosis, and you get multiple Kaplan-Meier birthmarks. You get these Lish nodules in the eye. You can have learning disabilities 50% of the time, but a lot of the time people are absolutely fine. And you get these neurofibromatomas, and some of them can turn malignant. Penetrance is really high. That's the amount of people who show a symptom. So penetrance is 100%, but it's really, really variable. So I think I've got some pictures. So some people get these quite significant growths over the body, whereas others might have a few birthmarks. And just because your dad has a few birthmarks doesn't mean the son's going to have a few birthmarks. It can vary hugely in families, which is quite difficult. There is an increased risk of cancer, in specifically breast cancer in females. I'm not a big fan of this because it doesn't give you a percentage. It says a 6.5-fold risk. And I prefer to give patients an actual percentage, makes it a bit easier to understand. But you can see the risk for NF carriers. They say by 85 years, it's 59%, but the general population is 50%. So overall, it's not a huge increase. It tends to happen at a younger age though, and it might be slightly different cancers that you expect to see in the general population. And it's very similar to other high-risk cancer surveillance. So all ages breast awareness, from 40 annual mammography and from 52 yearly mammography for NF1. I think this is my last one, Ponzi Jaguar, Hertz Jaeger. This one's an interesting one because you get this mucocutaneous pigmentation on the lips and other mucous membranes. So again, when you're doing a workup over the phone, you tend to have to ask people, do you have freckly lips? And they usually laugh and say no, and you think, great, okay, we can knock that one out. It's a very rare one. It's got a high de novo rate. So 45% of the time, there's no family history. They're the first people to present with that. And the female breast cancer risk, you can see it's increased by about 45% by the age of 70, where it's usually about 12%. So again, if you know that you've got Peutz-Jeghers syndrome, we can put screening in place to stop that. We'll catch it early. And so here's a Peutz-Jeghers pedigree, and you can see that there's polyps. They do tend to develop haematomatous polyps. And then we've got breast cancers. Interestingly, there's a breast and ovarian cancer there, which would make me think of BRCA, but we don't know if it's a high-grade serous cancer, so it could just be a red herring. The questions will wait until the end, but I strongly recommend that you have a look at the EviQ website. It's a brilliant resource. It's a resource for cancer practitioners, GPs, nurses, genetic counsellors, anyone who works in cancer. Okay, thanks very much.
Please introduce to you Sarah O'Sullivan, who is a clinical genetic counsellor. Sarah has worked as a clinic genetic counsellor since 2005, and she is currently a senior genetic counsellor within the familial cancer program at Genetic Services of Western Australia. She also works in private practice. And Sarah's going to speak to us today about rare hereditary cancer syndromes. Please join me in welcoming Sarah. So thank you so much for giving us the opportunity to talk today about genetics. I'm talking about the rarer hereditary cancer syndrome. So Sarah's spoken about the more common ones that we see. So it's always good to have an opportunity like this evening where we can kind of get a bit more awareness out there about the rarer predispositions. So by definition, a rare disease is one that affects less than 1 in every 2,000 people. That's the Australian definition. Most countries use the same definition. It's a bit of an overlap with Sarah's talk, but I've listed a few of the rarer conditions there. One of the difficulties with rare conditions is the limited data. So there's kind of a pinch of salt to be taken with these prevalence figures because there's a bit of uncertainty around rare conditions. But you can see that all of them are much less common than 1 in every 2,000 people. And you can compare those figures to the bottom BRCA that Sarah spoke about, and Lynch syndrome, which is one of the other relatively common cancer, genetic cancer predispositions that primarily predisposes to hereditary bowel cancer, also endometrial cancer, ovarian cancer, and a few others. So I think Sarah said 1 in 500, 1 in 400, thereabouts. You can see that, relatively speaking, they're a lot more common than the conditions that I'm going to talk about today. So rare conditions pose a lot of challenges for patients and for healthcare providers. I have not exhaustively listed what those issues are, but there's just a few down there that have familiarity not just with the rare cancer syndromes, but any rare condition. So diagnoses are often delayed. Conditions are complex and healthcare providers might not have familiarity. They might not in their decades of practice ever seen a particular rare condition. And some people don't have the time or perhaps the inclination to find out more. Patients can feel isolated. So there's a lack of understanding from healthcare providers sometimes, from their acquaintances who might have never heard of the condition. They can feel frustrated. So they're going to healthcare providers for information, and their lack of expertise means that they can't receive that. And what often ends up happening is the patient becomes the teacher, and they end up learning and telling their healthcare providers what they know about the condition, what they've learnt themselves.
There can be, with these conditions, they're often multi-system, and so lots of different specialists are needed to manage the different aspects of the condition. So there's often a lack of coordinated care, and that can create frustration. And patients sometimes comment that they feel that they've been put in a too hard basket because people don't know the condition, they're complicated, they need lots of different aspects of care to be taken care of, and sometimes they feel somewhat neglected by healthcare professionals. And all of this can lead to mismanagement, lack of compliance on the patient's behalf, and ultimately poorer health outcomes. So again, great to have opportunities like today to spread a little bit of information, and even if this talk, who knows, might end up in a referral that leads to a diagnosis of just one patient, that's a huge difference. So I'm going to go through a few case examples just to give you a little bit of a better understanding of some of these conditions, not covering all of them, but hopefully the issues are often relevant to different conditions. So the first case example is around a condition called Birt-Hogg-Dubé syndrome. So the patient is Susan, who's 36 years old, and she's experienced multiple pneumothoraces since she was about 18. Sometimes people will know of the association with pneumothoraces and Marfan syndrome, which is a relatively common genetic condition, but Susan doesn't have any of these features. In her family, there's her father who had renal cancer in his 50s and what Susan describes as lung issues. So I guess a GP's question might be, well, does this warrant a referral? Sarah spoke about Everq, and I think we're going to harp on about this because it really is a wonderful resource that anyone can access. And as she mentioned, the referral guidelines for GPs are a really important and useful resource. So I would encourage everyone to go and have a look at Everq after this evening if you haven't already. So Everq can help guide the answer to that question. But another option, if ever you just want to get a little bit of guidance on your patients, is a referral warranted. You can always speak to a genetic counsellor at Genetic Services of WA. I've got the contact details at the end of this presentation. So for Susan, the pneumothoraces, the family history of renal cancer do raise the question of Birt-Hogg-Dubé. So yes, a referral is warranted. So what would happen? So a genetic counsellor would contact Susan to take a detailed personal and family history, address any immediate queries that she might have, and explain what the process is to her. Because I'd say a lot of the time, I was going to say half the time, I'm not sure if that's a reasonable figure, but a lot of the time when people are referred to us, they either don't know that they've been referred to us, or they have no idea about what it means to be referred to us and what is this all about. So Sarah's already mentioned that a really important part of the role for a hereditary cancer genetic counsellor is validation of reported family histories, because we know that what is reported is often not what the reality is. And Sarah gave a few examples of that, and particularly in the gynae setting, people often say someone had ovarian cancer, and very often it turns out to be cervical, endometrial, gastric, something completely different, but not ovarian. So validation of records is really an essential part of our assessment. We would then offer either face-to-face or, in COVID times, as we now commonly say, a telehealth appointment routinely to go through the issues and the assessment in more detail. So for Birt-Hogg-Dubé syndrome, there is genetic testing available for the FLCN gene, and in Susan's case, that was offered. And just to note that, a bit like when Sarah was mentioning with Cowden syndrome, one of the things that we ask about is large head size. In Birt-Hogg-Dubé, they can get fibrofolliculomas of the skin, and there's a picture there of what that might look like. So that might be a question that we ask in the workup of a referral. So when she comes along, what we're all about, in a nutshell, I always say when I'm asked to party, that what we do is provide information and support around genetic conditions. We, in a quite short amount of time, get to know the patient, what is important to them and their family, how to discuss information. So we want to be discussing what is usually quite complex information in a way that is understandable and meaningful to them. We don't have to go into a great amount of detail. We don't have to tell them what we know. We just have to present the meaningful bits of the information to them. We might take different approaches for different people. So some people might be really statistics driven, numbers driven. Other people, it might be more meaningful to give them information in diagram form or in picture form. So really it depends on the individual in front of us. And ultimately we are also helping to facilitate informed consent around whether they want to have genetic testing, what that would mean for them and their family. So for Susan, we did the testing, found a gene fault, pathogenic variant, mutation, they all mean the same thing. And at her results appointment, we would discuss what that means in terms of healthcare implications for herself and for the family. And I guess that might be a bit of a difference between our specialty and a lot of others, where the focus is on the person in front of us, but very much we're mindful of the family and what the genetic implications are for biological relatives of the patient in front of us. So from the GP's point of view, we, after the appointment, send a summary letter and make sure a copy goes to the GP and any other doctors who are involved in the management of the patient's care. So moving on to case example number 2, which is around von Hippel-Lindau syndrome. So this time we have a child, James, who is 12, and he was diagnosed with bilateral pheochromocytomas. I'm going to say pheo from now on because it's too hard to say that many syllables. So in taking a family history, we see that it's quite minimal. So he had a grandfather who had bowel cancer in his 80s. But referral is warranted because it's an unusual tumour type and he's a child, so he's very young. It's a young age at onset. So in this setting, we would offer a testing of a panel of genes that are associated with pheos. Listed them off there. Not going to test you on it later, don't worry. But the important take home is that we found a pathogenic variant in the VHL gene, making a diagnosis of von Hippel-Lindau syndrome. I won't go through the host of conditions that are associated with VHL, but they're presented there. So if you know that someone has got VHL from a very young age, surveillance would be beginning from around 1 year of age, because that's when symptoms can manifest. Surveillance guidelines, again, available from Everq, very helpful in the management of patients with VHL. As you can see, it is a multi-system disorder, so there are lots of aspects of care that need to be managed. One of the things that's important in James' family is that he's got a younger sister, and the parents are worried that perhaps she's got VHL as well. So having identified that gene fault in James, we would then test the parents, and in this situation, both of them have tested negative. So this is quite reassuring because it's saying it's unlikely that other children that they have are going to be affected. So probably, Sarah was talking about de novo mutations earlier, this is likely to be the case for James. And we know that in VHL, around 20% of them are de novo. There is a small chance of it's a rather complicated thing called gonadal mosaicism, which means that in either the egg cells of the mum or the sperm cells of the dad, there might be a subset that do contain the mutation, But because we do testing on blood, if we test their blood, we don't find the gene fault, we're not testing what's reflective of the sperm cells or of the egg cells. So there is a small theoretical risk that there could be gonadal mosaicism, which would mean that the sister could be affected. So in that setting, we would actually go ahead and offer testing, even though the parents have tested negative, which we did in this family. And fortunately, she had a negative result, so that gives great reassurance to the family. Now, Sarah has already really nicely presented Lee Framini, so I'm going to kind of quickly skip over this one. But Mary is 32 when diagnosed with a triple positive breast cancer. The family history is striking. So if we did that, the nice pedigree that Sarah was presenting, it would also be very colourful with all these different types of cancers that have presented in the family. Together, they would represent classical Lee Framini syndrome. And usually this is caused by an identifiable fault in the TP53 gene. But that's not always the case. So even though the family has met quite clearly the clinical criteria for a diagnosis of Lee Framini, we've not been able to identify a gene fault. So we would still manage the family as though we'd still manage Mary as though she had the condition. It does, though, get a lot more tricky for the relatives, particularly as we move away in relatedness from Mary. Could they be affected? How should we manage them? The predictive testing setting that Sarah described, where you found a gene fault and then you can go on and offer testing to relatives that's going to give a positive or negative result, it can't be done. So yes, genetic testing does not always provide the answers, and it's not always as straightforward as you see on TV. You don't get your results as you're talking then and there, unfortunately, and it doesn't always, it often, I'd have to say, doesn't give black and white answers. There's a lot of grey in clinical genetics. So in conclusion, we know that rare cancer syndromes and rare conditions in general present unique challenges that often require providers to work together to help to diagnose and to manage the patient as well as their family. As the last case example just demonstrated, genetic testing is not always the answer, doesn't always give clear-cut information. And importantly, as I noted in one of the earlier slides, as a GP or as a healthcare provider, if you've got any queries, contact your genetic counsellor, because we will be able to guide whatever your query is. There are different options, but I've put the contact details of Genetic Services of WA up there. We have a duty genetic counsellor every day of the week who is there ready and waiting to take your call. So please don't hesitate, and email is another option. I think that's it.
Okay. Thank you very much to Sarah. Our third speaker for tonight is Cassie Nichols. Hi, Cassie. Cassie's going to be speaking to us about new and emerging technology and research in the familial cancer field. Cassie is an Associate Genetic Counsellor at Genetic Services WA. She's worked in a number of roles in the familial cancer field, including clinical research and the Familial Cancer Registry. She's particularly interested in research opportunities for patients and the long-term management of inherited cancer conditions. Please join me in welcoming Cassie. Thank you so much for having me here to speak tonight. Like the other two who've spoken tonight, I also work in the familial cancer program, and over the years I've had lots of different jobs, and it's given me the opportunity to really get an appreciation for familial cancer research and the long-term follow-up of patients who
might have a cancer predisposition condition. So today I'm here to talk to you about kind of the extra things that we can offer to patients other than our purely clinical genetic testing and counselling and that kind of thing. I don't have any disclosures to announce. So in WA, we've been offering BRCA testing for about 25 years. And thank you to Ratna at the lab who provided me with this timeline. She was there when testing started, so she was able to give me a rundown of what testing was available and when. I won't get into the specifics of genetic testing, but basically when it first became available for the first few years, we were testing BRCA1 and BRCA2 for patients who have a suspected hereditary breast and ovarian cancer syndrome. And the testing wasn't great. It was expensive, it was time consuming, and it didn't actually look at the whole gene. So they had the ability to look at certain sections of the gene, but there were big parts that were missing, and there was also all these other genes that Sarah and Sarah have spoken to us about. And if we fast forward to what we can do now, in 2020, we offer people what's called panel testing. It's done by next generation sequencing, and it means that when we see people for genetic testing, our lab is able to get data for lots of genes all at the same time. So it's fast, it's cheap, and it gives us a lot more information. And the testing is really good nowadays. So there are people who were tested in 1995 who we didn't find anything for. If we retest their sample now, we can get them an answer, maybe because they've got a gene fault in a different gene, but it could also be just because our technology is better now. And that leads me to the first study that I'm going to tell you about. I should say this is absolutely by no means an exhaustive list of all the different research projects that we're involved in. It's just some of the kind of bigger, more sometimes high profile ones that people might have heard about. I thought it was really important to let you know what they stand for, and that's mostly because if anyone asks me, I'm not going to be able to tell you what all of these acronyms are. But the brass strap study is something that we've been involved in for a number of years. It's the largest national clinical set study of breast cancer susceptibility. It's going for 5 years, and they're hoping to test about 30,000 women of 30,000 DNA samples of patients. It doesn't just have to be women. And what they're looking at is doing this panel testing. So they're looking at about 24 genes that are commonly tested around Australia in different labs for people who have a suspected breast cancer susceptibility syndrome. And these 24 genes might not be all that have a clinical impact if we find a gene fault. So they're, in addition to, the BRCAs and the other ones that Sarah spoke about, there's also these candidate genes that we think might be associated with breast or ovarian cancer, but we just don't know enough about it. So hopefully the brass strap study will generate information for that. So far, WA, New South Wales and South Australia have been involved in the study. It started in 2017. And what's included is DNA samples for anyone who has had an inconclusive BRCA test. So anyone in all of the years that we've been testing that we didn't find a gene fault in, they were included. They were trying to recruit Queensland as well, but there have been some issues there. And Victoria has kind of their own equivalent, so they decided not to participate in brass strap. So as I said before, we've been recruiting, or not really recruiting, but we've been sending patient samples since 2017 was the first batch. And that first batch went back 20 plus years. So it included over 2,000 patient samples. It was a huge undertaking for the lab and for us to kind of find out all those people. But as we're going forward, there's less people to send over. We've given the lab the numbers for the third batch, so nearly 600 samples in the next few months will be sent over. And it's anyone who's had BRCA testing, so it's not just women with breast or ovarian cancer. There are some men who have had prostate cancer, and there are some male breast cancers. There can be some obscure things. We didn't, we didn't divvy out certain things. And in addition to potentially reporting back clinically significant findings for genes that we're then going to offer testing to people or change their risk management guidelines, we're also trying to understand variants in some of these genes like CHEK2, how Sarah mentioned that only one specific variant is tested for, and like ATM, we're trying to understand other variants there. So for people who have those, we're not necessarily going to be offering testing
to other family members and changing things for them, but we are going to try and recruit them to the K-Confab study, which I will tell you about in a minute, to try and better understand those, because that might lead in the future that finding someone who has one of these variants changes their management. This is the results so far. So this is 2 batches of the bra strap study. As you can see, because BRCA1 and 2 have been tested for the longest time, everyone had BRCA1 and 2 testing, there haven't been that many found, but there are some that were missed earlier, and not unexpected. The other genes that we've been offering testing for less long, we have found gene faults in. The check 2 was really interesting because we were the only state that asked to have this back. At the moment, there's not FAQ guidelines, or if there is, they've only really just recently come in. And so a few years ago when we went to a conference and they said that WA had asked for this back, that was, why are you doing that? And now everyone's doing it. So we just led the country, and now we've got probably the most amount of families. The bottom one, MSH2, MSH6 and PMS2, Lynch syndrome isn't really associated with breast cancer so much. As Sarah said before, it's a bowel and endometrial cancer, but there is some association, and it was something that they reported back to us. Of those total 75, we've been able to contact 60 of those families, and that's led to a clinical significance for either the patient themselves or for their families, because we've then been able to offer testing. So that's a pretty significant thing for a lot of families. And I mean, I haven't been involved in reporting back these results to every family, but everyone that I've had contact with is really grateful that this is something. And it's nice that, you know, genetics hasn't just forgotten about them, that they have been rethought of. So K-Confab, as I said before, they're who we're going to be sending our variants that we don't really know what to do with to, our families. And that's what K-Confab stands for. It was established in 1997, and it's run by a lady called Heather Thorne, who is incredible. There used to be nurses in pretty much every state who would recruit to K-Confab, and the families that they recruited, they have quite a strict criteria. They have to have a certain number of breast cancer patients, and you have to be able to recruit at least a certain number of affected and unaffected families. We were lucky enough to have a nurse over here who retired in 2018, and just because of what happens with research, unfortunately, there isn't any extra money to rehire her. So at the moment, the whole of K-Confab is run by pretty much Heather. There's in-kind support, and she has one person to help her. So it's a big job. K-Confab isn't actually a study itself. It's more a resource for other projects. So they recruit these families that have strong histories. They collect a lot of data, and they pretty much send out questionnaires to these families who they've got probably 8+ members of every year to try and keep updating the information on the families. They also collect samples if these families are having surgeries because they've got breast cancer, or if they're having prophylactic. So they've got this huge biorepository as well. And with all of that, they've been able to contribute data to over 180 research projects. So K-Confab's pretty huge. These days, we don't recruit very often to it because there's not someone here to recruit. They don't have the resources. So it's mostly at the moment we're dealing with K-Confab either through families that have been recruited for years or because of those bra strap ones. There's an agreement with K-Confab that we're going to be recruiting certain families to try and learn more about these new genes. ICON is something quite close to my heart. I was the ICON state coordinator while we had money for it. It was one of my many jobs, and it was established in 2013. There was a coordinator in every state, and then 2 in Victoria were kind of the central coordinators. The idea of K-Confab was to set up a network around Australia. There was lots of in-kind support. There are geneticists, there are people in the lab, there are research people, all contributing. There's still a monthly meeting. It's all pretty much in-kind support nearly that keeps it running. But what it was, it made that network to make research easier to do, and it really fostered the next generation of people who might want to get into clinical research. These are a few of the ICON projects that we were able to work on, and we are still working on things. It's just things move a little bit slower nowadays. The biggest project was the ICON database.
So this was a pretty ambitious project. We wanted to make a national database that encompassed everyone in Australia who has a cancer mutation. We got ethics approval. New South Wales was very, very hard, and the amount of stuff that they were able to give us was limited, but it is there. And what we're actually working on now is trying to change that database into an identified registry if people want to be on it. What the database can do is give us an idea of how many people have whatever mutations, what research do we want to do, what do we want to learn more about. And so it gives us a whole heap, kind of gives us a big, just like CACONFAB, I guess, that was the idea, that research projects might be able to use the database to generate and potentially recruit through the coordinators. AGHA is something that you might have all heard of, the Australian Genomics Health Alliance. They have lots of different research projects, and we were involved in the ICON flagship. And what that did was, these families who look like they've got a cancer syndrome, but they don't fit with the other ones that we've talked about, we recruited them to this study. What they got was 101 cancer genes. So instead of kind of targeting for genes that might be associated with breast cancer or genes that might be associated with this, we cast the net really wide, and it was about looking at the cost effectiveness of that. Did that change patient management? Did that change what we were recommending to families? In WA, we recruited about 30 people from about 27 families, and we've got about 20 results back. So there are still a few that we're waiting on. Unfortunately, it didn't change anything. We didn't find anything, but other states did. The EVIQ audit was something that we looked at. So you've heard from Sarah and Sarah about EVIQ. It also has really good risk management guidelines for patients, what they should do with different gene faults. And what we looked at was different periods of time before EVIQ was around to when EVIQ was around. What recommendations were people given? So we looked back at the chart, and then we also talked to the patients to see, what were you told and what are you actually doing? Because is there a reason that you're not doing something? In case that could change management, what are the barriers there? And this is one that we're still currently recruiting for. Some people are, when we do genetic testing, and we haven't really touched on this, sometimes people can be given what's called a variant of uncertain significance. So that means that we look in one of these genes that we know can predispose to cancer, and we find a gene change that we don't know if it's something that's harmless or something that can cause cancer. And sometimes we find these variants of uncertain significance, and we tell someone this is a variant of uncertain significance. And then later down the track, we can tell them, actually, no, it is something that's pathogenic. Sometimes it can go the other way around, in that we tell someone they've got a pathogenic variant, and then we have to take that back and say, actually, we don't know what that means. And what that study was doing was looking at, what did this do to a family? What was it like being told that, so that we can try and understand that and just improve patient care. And the IMRC is the International Mismatch Repair Consortium. So that looks at Lynch syndrome, which I mentioned before is associated with colon and endometrial cancer. This is an international study. We contributed data to that to try and understand what's the penetrance of Lynch syndrome in different races in different places, really. And so that's been a huge project that we worked on. These are some of the things, as I said, ICON is still going slower, but hopefully we'll be able to make more studies. So ANGELS, again, is another acronym. And this is for people who we think have Lynch syndrome. So when someone's diagnosed with endometrial or bowel cancer, there's actually a screening test that can be done on their tumour, which really tells you whether you should refer to us because it looks like they've got Lynch syndrome, or whether it looks like they don't have Lynch syndrome. And a lot of these people that are referred to us that their tumour looks like it's Lynch syndrome, when we do the actual genetic test, we can't find what that genetic fault is that's causing the tumour to look like this. So we're left with, is this Lynch syndrome and we just can't find the mutation? Or is it not? Is it something sporadic that's happening in the tumour that we just don't have the technology to find? And that's exactly what ANGELS is for. So for all those patients where we're not able to find a gene fault, but we think that they've got Lynch syndrome, or it looks like they might, we send them to this study, and they're using really good technology in a research lab, and they're looking at blood and tumour DNA to try and find a hereditary cause. That might then mean we can offer testing to other family members, or they're trying to find a non-hereditary cause that might, in a way, let a family off the hook because we've got an explanation for your cancer. We don't need to worry about it for other family members. And in addition to people who look like they have Lynch syndrome, they're also interested in understanding why people are diagnosed with colon and endometrial cancer at a young age. So anyone under 45, if we don't know a clinical genetic cause for that, we can also send them there as well. We've been sending people here for about 2 or 3 years. We haven't got anything back yet. So when we send people to research studies, it's important that they understand this is not a clinical genetic test. You might never hear back from us. It could be years if you're going to hear back from us. So GCPS is actually run by the same people who run the ANGEL study. They're based in Melbourne, and as you can tell, they're interested in bowel cancer or bowel polyp conditions. It's for people who have polyposis where either they don't fit a gene that we know about. One of the big ones that we know, which you all might have patients, is something called sessile serrated polyposis. And that predisposes people to lots of sessile serrated polyps. We don't actually understand the genetic cause of that, so we can't offer clinical testing to these patients. This study is looking at lots of genes. Do I need to be quicker? Okay, so basically this study is for people who have polyposis conditions that we don't know about. It gives certain people an option for having testing when they might not be available in a clinical setting, and it doesn't look like a big thing. We've had one family in the year that I know of, in the years that we've been recruiting there, but identifying just that one family has meant that 7 people in that family could then have testing to know if they need to have increased surveillance or if they're not at risk of what's running in the family. Traceback is for, so people, there are lots of people that are referred to us who have a family member who died of ovarian cancer. Unfortunately, it was in a time when testing wasn't as readily available as it is now. And sometimes in those families, we can't offer any testing clinically. Traceback, they can self-refer or be recruited, and it means that they'll test tumour tissue of these relatives when it's available to potentially give an answer. And then this is my last slide. The Familial Cancer Registry is not a research project, but it's something that's very close to my heart. I work for the registry, and what we do is we follow up people who have either a gene mutation, a gene mutation predisposing to cancer, or some people who have a family history that increases their risk. We monitor their surveillance, we provide reminder services. We're an advocate. Lots of people are told you don't need a colonoscopy for 3 years when you're supposed to have it every year. So we are kind of that angel on your shoulder, and I feel like we've saved a lot of lives. So that's my end slide. Thank you very much.